Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
CardioNerds. My name is Evelyn Song, and I am a Hopkins internal medicine resident, future cardiologist, and a diehard CardioNerd. I am very excited and proud to announce that I will be one of the chief fellows for the upcoming CardioNerds Academy, where we will work together to learn, produce, and disseminate digital education for everyone. So stay tuned for a bright future in asynchronous medical education. We hope you enjoyed this phenomenal episode, the 9th part of our in-depth prevention series produced in collaboration with the American Society for Preventive Cardiology. We get to learn all about diabetes mellitus from Dr. Dennis Bruemmer, an absolute authority who is double-boarded in endocrinology and cardiology. Diabetes is a potent risk factor for cardiovascular disease, so let's learn how to fight it together. We thank you for subscribing to and supporting the CardioNerds. Our mission is simple: to democratize cardiovascular education. This podcast is not meant to be used for medical advice. The views expressed here do not necessarily reflect the opinions or policies of our employers. The case you're about to hear is HIPAA compliant. Now, let's dive into the sugary world of diabetes mellitus.
Hey CardioNerds, it's Amit here. We are so excited for this installment of our cardiovascular prevention series with a deep dive into diabetes, which I think you'll learn by the end of the episode is so important for us CardioNerds to pay attention to. We're joined by a phenomenal and true genuine expert in the field, Dr. Dennis Bruemmer. He's the director of the Center for Cardiometabolic Health in the section of Preventive Cardiology and Rehabilitation at the Cleveland Clinic. Dr. Bruemmer earned his MD and PhD degrees from the University of Hamburg in Germany. Following residency training in internal medicine and cardiology in Berlin, Dr. Bruemmer completed a 2-year research fellowship as the Diabetes Center Fellow in the Department of Endocrinology at UCLA. He is board certified in internal medicine, endocrinology, cardiovascular disease, and echocardiography. Quite a unique combination. And Dr. Bruemmer's research is focused on mechanisms of atherosclerosis and risk factor intervention for the prevention of coronary artery disease. Dr. Bruemmer, it's such a pleasure to invite you to the show. We're so excited to have you on. And as I invite you, I'm going to just reflect on your unique training path. We were just discussing before we started the recording here that there's going to be probably a lot of interest in pursuing some sort of combined diabetology, cardiovascular education for a cohort in the future. But would you mind just telling us how you got interested in really devoting yourself to cardiometabolic disease and diabetes in general?
Yes, absolutely, Amit. So first of all, I'm super thrilled to be here, and I'm so excited to be talking to the nerds here tonight. So I think it's phenomenal what you guys are doing. And again, I very much appreciate the opportunity here. So I'm kind of bridged between endocrinology and cardiology. Back in Germany, I did my thesis actually in endocrinology and lipoprotein metabolism, and that kind of got me interested in cardiology. I went to pursue cardiology training back in Germany, and then a research fellowship at UCLA. I was supposed to go back after that to Germany, but I decided to stay. And then obviously being a foreign graduate here, I repeated training, and I was always torn between the endocrine and preventive cardiology aspect and true cardiology. So I ultimately decided I'm just going to do both. So I did endocrinology fellowship and cardiology fellowship at the University of Kentucky. I had a phenomenal time there. And kind of still, even now, much of what we do in cardiology is really prevention, and that much of it is endocrinology. So I think these subspecialties really are complementary and work very closely together.
Well, let me just say on behalf of everyone here at the clinic, how glad we are that you decided not to go back and stay here and join us over here as a faculty, because you've just added tremendous value to the program and you've been such an incredible resource for all of us. So we thank you for being here.
Yes, Dr. Bruemmer, and I extend that thank you because, you stayed and here we are. talking to the nerds. I think this is totally fortunate, and I am really happy to benefit from your staying here. Now, we are very excited to dive into cardiodiabetology, which begs the question, Dr. Bruemmer, we are cardio nerds. Why should cardiologists focus on diabetes? I mean, why not just refer our diabetic patients to endocrinologists or leave the A1C to their primary care doctors?
Yeah, I think that's kind of the common theme, and that is the current care. We leave it to others in cardiology. Now, I think that is suboptimal. I think we as cardiologists, we see these patients all the time. I mean, when is there ever a patient in the cath lab that presents with an NSTEMI or STEMI that doesn't have diabetes? So we do see the far spectrum of this disease, of the cardiovascular complications that arise of having a diagnosis of diabetes. So I think we have to be involved in managing this. I think to a minimum, we should refer the patients to primary care or make sure that the diabetes is well managed or consult endocrinology. Now, as we all know, as physicians, quite frequently, not even that happens. So, and there's good evidence for that. If you look at registries, just about 6% of diabetic patients with cardiovascular disease actually get appropriate care for their diabetes and their cardiovascular condition. So, I mean, as you know, diabetes is associated with a 2 to 4-fold increase in risk. It is a cardiovascular risk equivalent termed many, many years ago. 70% of our acute coronary syndrome patients have diabetes. So you could argue, yes, we leave it to primary care, or the endocrinologists, but keep in mind that endocrinologists currently see about 5% of the patient population with diabetes. In the United States in 2012, we generated 280 endocrinologists per year. And these 280 endocrinologists are going to enter the workforce and per year and are supposed to take care of 100 million Americans with diabetes or prediabetes. So I think we have to expand the spectrum and we have to all work together. I think that's important to build collaborative networks between endocrinologists, cardiologists, and the primary care physician. We as cardiologists, we treat lipids, we treat hypertension. So why is it that we don't treat diabetes? We had the same discussion. I'm old enough to remember this in the mid-90s when statins were being mostly managed by endocrinologists. Then the cardiologists became more comfortable over time. And now we prescribe statin to everyone on a daily basis. So I think of all the risk factors that we manage, diabetes stands out. It promotes a spectrum of other risk factors, hyperlipidemia, hypertension, obesity, smoking is all very common in diabetic patient populations. So I think we need to address the whole spectrum of metabolic risk in these patients. And I think cardiologists need to be comfortable because these medications that we now have are vascular active medications. And there is a considerable therapeutic inertia. So I think there is plenty of room for all of us to do good medicine.
Well, thank you, Dr. Bruemmer. And, color me convinced. I think the jury is in. We as cardiologists just have to not only pay attention to diabetes, but really own it as a chief cardiovascular problem. Let's illustrate this further by getting back to a patient that many of our listeners will have gotten to know well by now from our case discussion and patient perspective episode, Amin. Let's recall that in 2015, at the age of 57, he was seen in clinic for polyuria, polydipsia, and blurry vision. Blood pressure in clinic was 152/102. His weight was 166 pounds with a BMI of 29. Labs had shown that his A1C by this time was 11.1 on diagnosis, and his urinalysis was positive for microalbuminuria. Thus, he was newly diagnosed at the same time with uncontrolled diabetes, hypertension, and an unhealthy weight. So, Dr. Bruemmer, before we dive into diabetes medications, can you give us your bird's eye view of a comprehensive approach to diabetes? What's on your mind for a patient like this, and what's on your checklist to do?
Well, as I mentioned, all cardiovascular risk factors are very common in patients with diabetes, not just sedentary lifestyle, overweight, hypertension, hyperglycemia, hyperlipidemia. So we see the spectrum in this patient. You haven't given us the lipid profile, but I would be stunned if this was normal. So looking at this patient that you just illustrated, you have plenty of opportunity to prevent cardiovascular events. And in this patient, the event rate is in the future going to be quite high because the patient already presents with microvascular complications. So this patient would very well fit the profile of a large cardiovascular outcome trial that was done in Denmark many years back called the STENO-2 trial, which was actually a collaborative approach between endocrinology and cardiology to manage exactly these patients. So if you look at patients that present with prediabetes or diabetes with microalbuminuria, the goal is really to use a comprehensive approach. For this patient, for example, you see first the BMI is above 27. By guidelines, if the BMI is above 27, you can already consider medical weight loss management for this patient. So that puts you in the step of weight loss therapy. Of course, foremost, the first step for these patients would be comprehensive lifestyle therapy. That is always, no matter what we discuss in diabetes, that is always the rule number one. We try to identify those patients that would be successful in engaging in lifestyle change. And that is not just includes medical nutrition therapy, physical activity. It also includes behavioral support, in addition, of course, to smoking cessation, obstructive sleep apnea. So what I mean by behavioral support is really patient empowerment, motivational discussions, maybe even counseling for other underlying reasons. In other words, you want to help first the patient to be able to take care of himself and to recognize this risk and not neglect the risks. I think you want to make sure that the patient understands what these risk factors are and how he and you are going to treat this. So we mentioned first cornerstone would be a lifestyle therapy. Second for this patient would be weight loss therapy, particularly with his body mass index. You would treat the cardiovascular risk factors. You would treat the dyslipidemia if he had one. You would treat the hypertension. Of course, for this patient, you would use probably already a combination of medications, at least including an ACE inhibitor and an angiotensin receptor blocker. And then, of course, you would treat the hyperglycemia. So these are sort of the main columns of care that you will address in this patient. We can dive more into detail, I guess, in the next couple of minutes as to what specifically, how would we treat his diabetes. But I think if you look at the overall approach, comprehensive care, including lifestyle therapy, including lipid management, including hypertension management, and including hyperglycemia management, yield, at least in clinical studies, at least a 50% relative risk reduction for cardiovascular outcomes.
That's a really powerful effect, Dr. Bruemmer. And, just to get closure on our patient, Kanak proceeded to lose 30 pounds and got his diabetes under control with just metformin monotherapy, as well as his hypertension under control with just an angiotensin receptor blocker monotherapy. And he told us, just being consistent along the lines of what you were saying, that the things that allowed him to be so successful were counseling from a team of doctors, his primary care doctor and his cardiologist. Being referred to diabetes education, he said, was absolutely essential. And his support structure at home, specifically his wife, giving buy-in and helping him maintain a healthy lifestyle. So I think a holistic approach is really important for him.
Absolutely. And this is a great example of how much of these risk factors are actually reversible. So.
Yeah, thanks, Dr. Bruemmer. That is a great way to systematically and comprehensively approach patients with diabetes. And I cannot even imagine a time, just going back to what you said earlier, that cardiologists were uncomfortable with prescribing statins. And so I look forward to a time that I myself will feel comfortable prescribing some of these anti-hyperglycemic therapies, and more importantly, taking the holistic approach that you're laying in front of us now and getting comfortable thinking outside of the box and really trying to meet my patient halfway in the different areas and domains that they need. So, counseling on healthy lifestyle is something many of us can improve on. Dr. Bruemmer, I'd love to learn what you say to your patients. Let's say I walk into your clinic with a new diagnosis of type 2 diabetes. What would you tell me about diet, exercise, and weight loss that would really make a difference and would stick?
Yeah, I think it is one of the most important steps. At the same time, it is probably the most challenging aspect of care. In addition, it is the aspect of care that has the most powerful impact, I would say, as we just alluded to in the previous case. So the way I approach these patients, and that's kind of along pretty much all the recommendations, but I think if you do this long enough, you kind of try to develop a sense in talking to your patient. Is the patient motivated? And it is a fact that many patients are not motivated. They say, well, no, I like my way of living. Just give me the pill and let me be. But I think you try to motivate the patient in a way to explain first what this condition means and what the risk associated with it is. And most of the patients then actually begin in the discussion to turn around and understand some of this. We here have pretty much all patients meet with a nutritionist to devise a medical nutrition therapy to achieve a 5% weight loss. We initiate medical weight loss therapy in patients with BMI above 27 and diabetes and cardiovascular disease. And of course, we provide exercise recommendations. But I think in trying to identify those patients that are motivated and try to identify the barriers, why a patient would not be motivated. Are there reasons? Socioeconomic reasons, cost. I mean, if you want to live healthy in the United States, it's terribly expensive. Okay, so highly palatable, highly dense caloric food is cheap. So we have a huge discrepancy there. And I think you try to work your way through as to how can you help the patient and how can you get to a strategy that works for the patient. So I think, again, that is probably the most challenging aspect. What I do is I always in the first encounter, I give the patient the benefit of the doubt. I tell them, you meet with a nutritionist, you meet with an exercise physiologist. We are lucky here because we have this infrastructure. If I identify barriers, we have psychology and psychiatric counseling available, which is phenomenal, of course. They will discuss motivational interviewing and things like that with the patient. So I usually then give the patient the benefit of the doubt. I say, give it a chance. And I tell the patient, try to lose 1 pound a week by weighing yourself and documenting your weight. I set a goal for a 4-week follow-up, and I say to the patient, I want you to come back in 4 weeks, and in 4 weeks, you've lost 4 pounds. And that sounds achievable, so you set small milestone goals and try to motivate the patient. Sometimes, again, there are those patients that are where you know already that that's not going to work, and then I think you start medical therapy very early.
Definitely hear that. So goal, small steps, and identification of barriers are just key principles. But obviously, sometimes pharmacological therapies are important. And so, some of the anxieties that I associate with prescribing new drugs that I'm less familiar with are sometimes cost related and having to do all this prior auth, work that is just like no one's favorite thing to do. But also unperceived side effects and drug-drug interactions that I may not have anticipated because I'm focused on the particular effect of the drug that I'm using, and I'm not really thinking outside of the box when it comes to the other effects that these drugs may have, especially if it's something that I'm not prescribing on a daily basis yet. So, in our patient, we definitely would want to start statin therapy for Mr. Amin at this point. But Dr. Bruemmer, isn't there data that statins may cause or worsen diabetes?
Yeah, whenever you have a patient and you name a new drug, you get a encounter call or email later on saying that where you can see that the patient educated himself on Google. So patients will come back and say, well, I have diabetes or I have pre-diabetes. When I'm on statin, am I going to get diabetes? So I think we have to see this in perspective. So this initial observation that actually came out of the Jupiter trial, looking at rosuvastatin in about 9,000 patients on placebo and 9,000 patients on rosuvastatin. And between both groups, there were 270 reports of diabetes in the rosuvastatin arm versus 216 in the placebo group. So there were more incident diabetes in the group of rosuvastatin. And that finding was actually later confirmed in meta-analysis. And it seems to be that there's probably about 10% risk in incident diabetes compared to a placebo comparison with statin therapy. Now, in patients without diabetes, statins may increase the fasting glucose level by about 3 milligram per deciliter, and that's been attributed to insulin resistance and insulin secretion effects in part. Now, while in patients with diabetes, high-intensity statin therapy may increase the hemoglobin A1C by a range of about 0.3. So if you put this in perspective, the effect is minor, but it is present. But the main point about this is that in one of the largest data sets that's actually available has shown that about 1 out of 255 patients treated with statins will develop diabetes over 4 years. So keep that number in mind. 1 out of 255 patients will develop diabetes over 4 years, but at the same time, you get the benefit of risk reduction and LDL cholesterol reduction. So in that same 254 patients, you would reduce 4.5 cardiovascular events. So yes, there is an increased incidence of diabetes, but putting this into perspective, would you rather have a 0.3% increase in your hemoglobin A1C or a myocardial infarction? So I would know my pick.
Thanks for going over that, Dr. Bruemmer. And now returning back to Mr. Amin, I'd love to learn more about your approach to initiating medical management for the diabetes itself. What is the relative benefit of lifestyle versus medication? And when do you start medication therapy? And as a first-line agent, what do we need to know about starting metformin?
Yeah, that's a very, very controversial area, actually. So the US guidelines still predict to initiate lifestyle therapy plus metformin at the time of diagnosis. And whereas the European guidelines have already shifted in patients with or at an increased risk for atherosclerotic cardiovascular disease, SGLT2 inhibitors or GLP-1 receptor agonists. So new diabetic agents with much more data for cardiovascular benefits have become first-line therapies, at least in the European guidelines. Keeping in mind, metformin, it's a good drug. The data for metformin use as a first-line therapy came really out of the UK PDS trial that had a sub-arm with 1,700 overweight patients. And in those 1,700 overweight patients, there were 342 patients taking metformin. And in the metformin group, there were 50 myocardial infarctions versus 69 myocardial infarctions in the group that was not taking metformin. So this data has really generated much of the guidelines. This would never work for the FDA in today's cardiovascular arena. So I think it's important to use metformin. I think we still use that. Even I use that, but mostly because payers will not allow you to write an SGLT2 inhibitor or a GLP-1 receptor agonist without proving that the patient has inefficient glycemic control with metformin monotherapy. That's the main reason why we still use metformin as a first line. I think the data is poor. I would wish we could use alternative medications as first line therapy. Oftentimes, most of the patients, keeping in mind they will need several medications, so we end up with a combination thereof.
Sounds like ideally you'd start with one of these novel agents, but practically you have to start with metformin, but then ultimately metformin plus, dealer's choice after that makes sense from a practical standpoint. And speaking of starting from anti-diabetic medications, which patients are ideal for sulfonylureas and TZDs? And Dr. Bruemmer, you'll have to forgive me. I Googled the long term of the TZDs, and I was like, I can't say this, so I'll just let you say what those are. And can you remind us how these agents work and what are their pitfalls?
So it took me about 5 years to learn the word. So here you go. Thiazolidinediones. Okay. So, but
well, that's definitely not how I would have said it, but good to know.
I had to practice this for a long time. So first of all, you ask about sulfonylureas and thiazolidinediones. So the oldest drug for diabetes is sulfonylureas. They're pretty much, I think, nowadays from a cardiovascular standpoint and from an efficacy standpoint and from a safety standpoint, actually, they're, I would say, almost, at least for a preventive cardiologist, endocrinologist, I would consider them obsolete. There's no efficacy data past 4 years. There's no cardiovascular benefit. In fact, if you look at large meta-analysis, increased all-cause mortality and possibly even increased MACE events in meta-analysis with sulfonylureas. So I try not to use those medications. We have safer medications and better medications. The TZDs used to be, of course, much more frequently used. They're quite efficient. They work by improving insulin sensitivity, mostly at the level of muscle. They actually work complementary. Metformin decreasing hepatic glucose production and hepatic insulin sensitivity versus a thiazolidinedione improving muscle insulin sensitivity. So they are good agents from a mechanistic standpoint because they target the defect in many patients with diabetes, that being insulin resistance. However, because of adverse effects, they're not being used much frequent. Although I have to say that pioglitazone has a kind of outlived their renaissance with more data and with very good safety data. Rosiglitazone, because of adverse cardiovascular outcomes, is almost not used at all. I haven't seen a patient taking rosiglitazone in a long time. So I think pioglitazone remains, from those that you discussed, from the sulfonylureas and from the thiazolidinediones, remains really the only option as a potential therapy based on data coming out of a trial called IRIS for stroke reduction and proactive trial and periscope trial. So those were all safety trials that had potentially even shown decreased coronary events, but definitely decreased incidence of stroke in the IRIS trial. And it's a generic drug. So I think pioglitazone is still to be considered.
Thanks for that. And you mentioned rosiglitazone and cardiovascular effects. And I have to say, in 2008, I wasn't quite wearing diapers, but I was definitely a much younger man. And I know that clinical trials for anti-diabetic medications now must include assessment of cardiovascular outcomes and safety. Can you tell us a bit more about the history behind this and why this rule was enacted by the FDA in 2008?
Yeah, I mean, this is, so first of all, I think this discussion was initiated by a adverse signal for rosiglitazone on poor cardiovascular outcomes. And this was a meta-analysis published by Dr. Steve Nissen here from our institution. There were follow-up meta-analysis done by Dr. Linkoff, et cetera, by others. So, and the data suggested that rosiglitazone has adverse cardiovascular outcomes. Now, the FDA was alerted by this finding and ultimately decided, because of the evidence that diabetes is such a vascular disease with poor cardiovascular outcomes, it was decided that any future diabetes drug will need a cardiovascular outcome trial. So the FDA really was responding to concerns about the potential for increased cardiovascular risk associated with rosiglitazone, and that led to a guidance on any future drug proving cardiovascular, at least non-inferiority compared to what's currently available. So now we pretty much know that any new drug that comes on the market in the diabetes field will need a cardiovascular outcome trial.
Yeah, that was a great discussion. And, I always love listening to Dr. Steve Nissen talk about the story from his perspective. It just reminds me of how many different roles a physician can play outside of clinical medicine. But hey, this is a clinical podcast. So let's get back to a patient I saw actually recently in my continuity clinic with Dr. Jaber. Mr. Wanka Goodbar is a 70-year-old man with a history of type 2 diabetes, with a hemoglobin A1C of 9.1%, morbid obesity with a BMI of 49, and a AAA status post-surgical repair, hypertension, non-alcoholic fatty liver disease, and atrial fibrillation, who returned for routine follow-up. His med list included metformin 1,000 milligrams BID and rosuvastatin 40 milligrams daily. He expressed a lot of frustration about his inability to lose weight. We really focused a lot of our clinic visit on this issue. And so here's what we did. We counseled him about weight loss and specifically calorie restriction, referred him to a registered dietitian, started a GLP-1 agonist, and we discussed the possibility of pursuing metabolic surgery, which he chose to defer until the next visit. So Dr. Bruemmer, I'd love your feedback here, and especially your perspectives on GLP-1 agonists.
So before I answer the question, Amit, congratulations. You've become now a hobby endocrinologist. So you're on board.
Well, I will say that it was after we started working with the ASPC and making these prevention series that really my worldview of the impact we can have in clinic changed drastically. So I will say this is a relatively recent shift in my practice.
I second that. It definitely has totally made me rethink so much, and it's definitely had a really positive effect.
Yeah, you guys are phenomenal. Again, this is exactly what we need. So you ask about GLP-1 receptor agonists. So just briefly in a nutshell, the GLP-1 receptor agonists, they bind to a GLP-1 receptor, which is found in the pancreas, of course, in the gastric mucosa. It's also found in the hypothalamus and actually in the heart. So through binding, these receptor agonists promote glucose-dependent insulin release and in addition have effect on gastric mobility, slow gastric emptying, so patients feel full, inhibit glucagon, and reduce ultimately food intake. So their efficacy to lower hemoglobin A1C is somewhere around 1%. There's really three main drugs that we now use for cardiovascular benefit. The first drug that was available, exenatide, was cardiovascular neutral, but liraglutide, semaglutide, and dulaglutide are those drugs now that have proven cardiovascular benefit in outcome trials. And they're fairly easy actually to initiate. We can discuss that in more detail if you guys are interested. But, I think in your patient, you did absolutely the right thing. You first counseled him about weight loss. You would try to support the patient on his path to losing weight. You discussed bariatric surgery. Combined with lifestyle, in clinical trials, GLP-1 receptor agonists lead to up about 5% total body weight loss, and that's the 5% that is recommended in the guidelines, and that we know from mostly look-ahead trial and a Mediterranean diet trial that 5% weight loss is what you need in order to lower your hemoglobin A1C. And, I think the patient also made the right decision to first attempt lifestyle modification, medical weight loss with a GLP-1 receptor agonist, and may ultimately proceed to bariatric surgery if really needed. So I think, Amit, congratulations on taking care of his patient.
So we've started metformin, and let's get a little bit practical. How do you start and titrate GLP-1 agonists, and what symptoms should we look out for?
So it is actually fairly easy to add these medications. I think first and foremost, you need to discuss with the patient that these are injectable medications. So the patient has to be comfortable to give shots. It is super easy, but there is the barrier initially so that the patient has to overcome. And there is now a oral GLP-1 receptor agonist which is the oral semaglutide, and hasn't shown cardiovascular benefit yet, but which can be used as well. So the three injectable, liraglutide, semaglutide, and dulaglutide, those are the ones that we use. I give you an example for liraglutide, which is daily injection. Semaglutide and dulaglutide are weekly injections. So if you were to use liraglutide, which, by the way, comes in doses from 0.6 to 3 milligrams, the higher doses, 1.8 to 3 milligrams, are what we actually use for pure weight loss indication. 3 milligrams of liraglutide has an indication for weight management, irrespective of diabetes. But to stick with your patient, going back to diabetes, so you would want to tell the patient first that this is an injectable medication. You would tell the patient this is an adjunct medical therapy to lifestyle change, including weight loss and exercise. In patients on insulin, you want to discuss the risk of hypoglycemia, potentially even lower the basal insulin amount, and that's where it sometimes gets already a little bit tricky. In my experience, the insulin is not that much of a problem because most of the patients that we see are not controlled. So you would tell the patient, you would counsel the patient on side effects, most common nausea, abdominal pain, diarrhea, up to mild increases in serum lipase and amylase, all the way to acute pancreatitis as a side effect, which is very infrequent and less than 1%. In fact, I've never seen this. So, and then you would tell the patient that you would give an injection. You would start at 0.6 milligrams with liraglutide. You would use that for 1 week. I have the patient call me after 1 week. If the patient tolerates it, I often keep the patient on that dose, although the package insert said you should increase that after 1 week. But I like to stretch this a little bit because if a patient is already losing weight and getting benefit at 0.6, I want to ride that out a little bit. And then usually the nausea becomes less after a while and the weight loss plateaued. And that's when I go ahead and increase the dose further to 1.2 or 1.8. And, semaglutide and dulaglutide are weekly injections. Patients pick a day of the week, take semaglutide 0.5 milligrams weekly or dulaglutide at 0.75 milligrams weekly. So starting these medications is actually pretty straightforward.
Okay, great. So he's down with the injectables and he's on board with diet and exercise. He's going to look out for the side effects that we just talked about, 0.6 milligrams liraglutide times a week. And we're going to look out for these potential things. Are there any contraindications that I should be thinking about that he cannot be on this medicine?
These GLP-1 receptor agonists have a black box warning for genetic medullary C-cell carcinoma of the thyroid, and that has been shown in rat models that there's an increased incidence of medullary C-cell carcinoma. So in those patients that have a family history of thyroid cancer or proven medullary thyroid cancer, it's not a drug you would want to use. I personally have never experienced that situation, though. But it's probably, you want to discuss that with the patient, of course, to be safe and to not miss that.
Great. Thanks, Dr. Bruemmer. And, we did discuss metabolic or bariatric surgery with him. The other day I was walking by Dr. Cho's office and I went in there and we just started talking about preventive cardiology and in our bariatric group here. And, she told me something that I didn't realize, that there's some data that bariatric surgery may be useful in diabetes management, even independent of weight loss. Is that true?
Yes, that is true. And that is because we now know that bariatric alters many of these gut hormones and may actually improve glycemic control that way, irrespective of weight loss. Now, you have to keep in mind, bariatric surgery, yes, it's very effective. It is very effective on improving glycemic control. It's very effective on sometimes even all the way to reversing diabetes. It prevents cardiovascular outcomes in a very dramatic way. But it is unless just a sleeve gastrectomy, if Roux-en-Y bariatric surgery is a fairly altering physiology surgery. So I think that's something to keep in mind. This is not a procedure that has no complications. These patients need to be followed, vitamin deficiencies watched, etc. So So I would always discuss that with the patient, and I would always advise to, and that's what most centers do, attempt medical or attempt non-surgical weight loss attempts first, which is definitely my initial approach.
Thanks for going over that. Let's move on to another case I had in clinic. Mr. Hershey Toblerone is a 70-year-old man with a history of type 2 diabetes, hypertension, coronary artery disease, status post prior CABG, HFpEF or heart failure with preserved ejection fraction, atrial fibrillation, and CKD, who returned to clinic for a routine visit. His metformin was actually stopped during a recent admission but was never resumed. His A1C actually is 5.7 on linagliptin and Lantus insulin, 30 units nightly. His fingerstick glucose values have actually been running in the 70s to 80s. So here's what we did. We stopped his DPP-4 agent linagliptin. We asked him to slowly down titrate his insulin and log his glucose values to achieve glucose levels closer to a more normal range because he was clearly well below a goal for diabetes. We made a plan to start an SGLT2 inhibitor once glucose levels were more acceptable. And since his A1C was well below goal, we thought maybe he could just transition to a non-insulin oral regimen, which is what he was on prior to his admission in the first place. So I'd love your perspectives with this case, Dr. Bruemmer.
Again, you're the hobby endocrinologist. I'm impressed. So what strikes you first and foremost is if you see consistent fasting glucose levels in any patient on insulin that reach double digits, you need to be alert. Okay. This is a 70-year-old gentleman, Toblerone. He's probably from Switzerland. But as a 70-year-old gentleman with multiple comorbidities, complicated coronary disease, HFpEF, AFib, CKD. So when you hear hemoglobin A1C of 5.7 and fasting insulin levels of 70, you got to be on the lookout. And I think, that relates then to the discussion, what would be the hemoglobin A1C goal for him? And this is where it clearly needs to be individualized. This was a 24-year-old type 1 diabetic patient on continuous glucose monitoring with a sensor. I would say perfect, no change. But for this gentleman, I think you absolutely do the right thing. And, again, once you get double-digit numbers, you want to be careful. And I think the hemoglobin A1C for him, I would probably be very comfortable if it's in the 7.5 kind of range. Keep it safe, okay? Do no harm. That's the rule number one. Now, DPP-4 inhibitors are not very effective and have no cardiovascular benefit. So I think you did the right thing to stop these. They, I think, probably belong like sulfonylureas in the category of medications that we should not be using any longer because, again, we have alternatives that are safer and better with cardiovascular benefit. So in addition, it's probable that the linagliptin had very little effect on lowering his hemoglobin A1C anyway. So I would probably suggest that most of his A1C reduction comes from the basal insulin. So, I agree. I totally agree with what you did. I would have probably just stopped the insulin and added the SGLT2 inhibitors. So, and then have the patient check and come back or report the logs, I think the SGLT2 inhibitor would, compared to placebo, reduce the hemoglobin A1C by about 0.7 percentage points. So an SGLT2 inhibitor would be an excellent choice, not just because of the risk to avoid hypoglycemia, but for this patient, also for cardiovascular event reduction. And I would argue renal benefit because he has CKD. We're not given the creatinine here, but, for such a patient, I think if you had started an SGLT2 inhibitor and you still needed additional medication to treat his hyperglycemia, I would probably have opted for oral semaglutide. which is a good option. It's a GLP-1 receptor agonist that's taken in pill form. So I think that might be an alternative, might reduce his hemoglobin A1C another percentage point. So depending on what his GFR is, you could have argued, well, maybe we can even resume metformin. So in addition, I think if the patient is not in clinical heart failure and we have financial issues, let's say his insurance will not cover an SGLT2 inhibitor and will not cover a GLP-1 receptor agonist, they want you to use glimepiride, then I would have probably opted to maybe even add low-dose pioglitazone for him, of course, unless he is clinically volume overloaded.
Great. Thank you so much, Dr. Bruemmer. And actually, the point you raised about being concerned about his double-digit glucoses, after we talked to him for a while, we realized that after he was started on insulin, he, after some time, received a diagnosis of mild cognitive impairment and was started on Aricept. So we were actually very concerned that his new short-term memory losses related to these hypoglycemic events that were going undetected.
Yeah, and I'll add that it's really fascinating to hear I'm like watching your brain like figure out which regimen is right for which patient, and just watching, listening to your thought processes is so rewarding. Again, it goes back to this whole holistic approach and, looking at every, patient and thinking about their underlying comorbidities besides for diabetes, helping you select the right concoction for your patient. And then you even have a plan A, plan B, plan C. It's quite actually fascinating. I know that SGLT2 inhibitors there's a risk for hypoglycemia and also euglycemic DKA. Can you talk a little bit about that?
Yeah, so, to relate to what you mentioned, there's a handful of drugs and it's not that difficult, actually. I think you got to know your ABCs for those couple of drugs. And then I think you'll be very comfortable to use them, like you use ARBs or ACEs or beta blocker or CORIC or metoprolol. So I think you'll have that down fairly well. So SGLT2 inhibitors, you mentioned hypoglycemia. So I would say in the absence of any additional glucose-lowering medications for diabetes, particularly insulin or sulfonylurea, I think the risk for hypoglycemia is exceedingly low. In one of the main trials, there was no significant difference in hypoglycemia frequency between placebo and empagliflozin, for example. So these are fairly safe drugs. We have data now on patients without diabetes. So I think this is a good drug for most of the patients that we see. So they're fairly safe medications. I usually use empagliflozin or dapagliflozin to keep it simple, starting at 10 milligrams or 5 milligrams respectively. The side effects that you can get with these medications, you have to be careful with dehydration, keeping in mind that these are sort of osmotic diuretics. So I do hear from patients frequently that they're super thirsty. So you are doing osmotic diuresis. You need to discuss with the patient the concern of genitourinary fungal infections. Mostly they occur in about 5 to 10% of the females. Mostly fungal infections, less in females. Also dysuria can occur, but what you mentioned, the risk of euglycemic ketoacidosis is pretty small, but it is notable. So you want to be careful in certain patients. Certainly you don't want to use that in type 1 diabetic patients, obviously. I'm sometimes more careful in lean patients or in patients that tend to do other severe means of dieting, intermittent fasting and things like that. So it's something to discuss with the patient, but it is very infrequent.
Yeah, I really appreciate you going over that. And I also appreciate you highlighting the risk of sort of surface genitourinary fungal infections, but not the more severe ascending urinary tract infections, which I think, has some people hesitate on occasion. Let's move on to another patient to highlight another role for these medications. Nestle Reeses is a 55-year-old man with type 2 diabetes, non-ischemic cardiomyopathy, with heart failure with low ejection fraction, hypertension, and CKD. He was admitted after developing a rash following initiation of spironolactone, which was subsequently stopped. He was euvolemic and on maximally tolerated doses of Entresto, and carvedilol. His A1C is 7.5 on metformin. So we were actually able to start SGLT2 inpatient after verifying he had insurance coverage, and we simultaneously sort of empirically reduced the diuretic dose that he was on at the time. So what is your perspective about the role of SGLT2 in this patient, Dr. Bruemmer?
Yeah, I think you used absolutely the right drug of choice for this patient because of benefit, both with respect to heart failure, rehospitalization, mortality, and also with respect to his chronic kidney disease. So, as you know, a large trial, one of the first studies with this class of medications, EMPA-REG trial, did show a significant reduction in cardiovascular and all-cause mortality, but also showed a 35% risk reduction in heart failure hospitalization. And it is assumed that the early separation in the curves between placebo and drug were actually driven potentially even by the heart failure benefit of this drug. So the benefit occurs very quickly. Two other cardiovascular outcome trials, DECLARE TIMI and CANVAS, showed similar, extended this to basically the class, dapagliflozin and canagliflozin, and most recently in the DAPA heart failure trial, the heart failure benefit with respect to rehospitalization and mortality was extended to patients without diabetes. So I think this is the right choice of drug. I think with respect to renal questions, empagliflozin, canagliflozin, and dapagliflozin, they all reduce progression of nephropathy in patients with a GFR above 30. GL2 inhibitors reduce worsening of nephropathy, reduce the frequency of doubling of serum creatinine by about 44%, and also reduce the progression of renal replacement therapy by about 55%. So these are all very beneficial outcomes for this patient.
Yeah, and we had Dr. Mentz from Duke Medical Center talk about a little bit about this as well. But it's quite interesting that DAPA-HF enrolled regardless of diabetes status, really making us think of SGLT2 inhibitors as a cardiovascular medication rather than just an anti-diabetes medication. So this obviously speaks to the pleiotropic effects of SGLT2 inhibitors on weight and blood pressure and renal outcomes. Could you expand a little bit on that?
Yeah, I think the observation that we see benefits for cardiovascular mortality events, and lastly here most recently for heart failure, is very encouraging. We haven't had a drug like this, a drug class, for many, many years. Cardiologists were always wondering, diabetes care doesn't really work because we have no drugs. But now this has really changed. So now we're actually, particularly because we see in DAPA-HF the benefit in patients without diabetes, now we're talking about heart failure medication that falls in the same category as Entresto, for example. So this has become a heart failure medication, and I would argue that this class of medication is a cardiovascular medication. And that kind of brings us back to our first point of discussion, that we're now using these drugs for a primary cardiac indication. So there is no way but for the cardiologist to begin to become comfortable using those. So, and I think that's why you guys are doing this, and I think this is phenomenal. You mentioned briefly weight loss, blood pressure. These are some of the effects that I think are mostly attributed to the energy loss associated with glucosuria and osmotic diuresis. The effect on blood pressure with SGLT2 inhibitors is about average reduction, probably about 4 millimeter mercury shown on 24-hour ambulatory blood pressure monitoring. So a meaningful reduction in blood pressure. Weight loss is mild in 12-week trials. Dapagliflozin, canagliflozin, and empagliflozin show about a 2 to 6 kilograms, so 4 to 6 pound weight loss. This weight loss appears to be sustained over time, which is excellent for patients. So this in combination, I think, makes this a very new and very promising drug. I think the main concern that we're dealing with is to expand use to the general population. That's what we have to improve now.
You really speak about it as a cardiovascular medication. I could really feel it. And I do think that, when all these studies have come out recently with the SGLT2 inhibitors, this is what re-engaged the cardiovascular community. You see it with the people that I work with, and you see it on, Twitter and social media. This is kind of what is drawing the cardiologists back to diabetes medicines. And it's just it's a great time to be in medicine. That being said, Dr. Bruemmer, what makes your heart flutter about cardiovascular prevention?
Well, I think, as a physician, what could you not love about preventing disease? That is the ultimate goal, right? We don't want to treat disease. We want to prevent disease. Doesn't this make sense? So why would you focus on treating a disease if you can start to or attempt to prevent it in the first place? Now, looking back in my own personal career, when I was back in training in Germany, we used to stent patients with chronic stable angina all the time. We would bring them back to the cath lab every 6 months to make sure that the stent was open. That was in the era before drug-eluting stents. And we would then re-stent and re-angioplasty. And now we know that that approach is obsolete. And simply put, the mechanical work doesn't apply. So the mechanical approach is not working. So we've become to understand that prevention does not only work better, but it's also more cost effective. In fact, I would argue that we're seeing that this is very true for patients even with moderate to high risk ischemia. Prevention just seems to work better. Looking at new data, you guys know that I'm referring to the ischemia trial. Now, who would not work in prevention nowadays? Looking at 100 million US people with diabetes and prediabetes, and 1 out of 5 adolescents with prediabetes in the United States, I think with the associated expected rise in cardiovascular disease, I think preventive cardiology is where the future is.
Well, Dr. Bruemmer, I will definitely raise a toast to that. Overall, this is just such a phenomenal and eye-opening discussion, really full of pearls and practical tips. With this episode, we are just arming a legion of CardioNerds to really own the management of diabetes in a partnership with their primary care doctors, endocrinologists, dietitians, diabetes educators, metabolic surgeons, and of course, the patients themselves. I think the impact that we can have with a holistic approach in this way is going to be great. And, we're just so grateful for your time and perspectives and helping us carry this message forward. Thank you, Dr. Bruemmer.
Well, absolutely. Dan, thank you so much for having me. And I think you guys doing a very important, if not more important job, because you try to educate. And that's exactly what we need to do. So I was thrilled to be here, and thank you very much. And please keep going.
Hi, this is Amit here. I'm president of the American Society for Preventive Cardiology and professor of medicine, director of Preventive Cardiology at UT Southwestern Medical Center. I want to first thank the CardioNerds podcast. What an amazing job these folks do, and really thankful that they've elected to do this prevention series. Prevention is so important and so fundamental to all that we do in cardiovascular medicine. And at the American Society for Preventive Cardiology, we're delighted to co-sponsor this series to really promote what they do, to share with all of you about the wonderful world of prevention and all the great experts that they're going to bring on these podcasts. We hope you get a lot out of this series. And if anybody wants to learn more about prevention, please reach out to myself or any one of these excellent speakers they have coming up. We're all pretty passionate about prevention, and we certainly want to help others learn about it too.